Hello again, friends. This will be a talk on bacterial vaginosis and pregnancy. Now, if you know what bacterial vaginosis is, you will know that most of the time, and especially outside of pregnancy, bacterial vaginosis is really not a big deal. Now, to the woman, it may be a big deal because it causes a discharge that might stink, but it doesn't really have any complications. However, if you put bacterial vaginosis with pregnancy, you can have some really big problems on hand for some reason. So it is important to understand those complications because it's all the more important to treat bacterial vaginosis and to detect it when the woman is pregnant if she comes to you complaining of a foul-smelling discharge. If you haven't already, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can click the link below in the description of the video or on the I button on the upper right hand corner of the video. It should link you up. If you could just consider chipping in $1 a month, a little bit goes a long way to help keep these videos free. And if you subscribe, you'll have access to some of my premium videos. And in those videos, I go over some cases and how you can put together a differential diagnosis, a diagnostic battery, and a treatment plan. And that will be very helpful to you if you plan on taking the USMLE Step 3, which is a necessary test to get medical licensure in the United States. But either way, if you want to learn how to do those things and it'll be useful for you for clinical practice, those videos are there for subscribers. So let's get on with it. Bacterial vaginosis is one of the infections that cause increased complications in pregnancy, along with the UTIs and group B strep. So BV is the most common lower genital tract infection in women of reproductive age. And the reason for this is that the genesis of BV is a disturbance in the flora of the vagina. And that flora is very well defined in women of reproductive age. And so once you disturb that, you can have some problems. We'll go into the pathogenesis in a little bit greater detail in about a minute. The incidence of BV is about 4 to 17%, but this was cited among private office patients, and private office patients tend to be a little bit more well-to-do, less likely to be lower socioeconomic status, and so it's probably higher than that in the general population. The prevalence in pregnancy has been cited anywhere between 6 and 32%, so it is something that is common, so you do want to be aware of this. It's associated with some adverse OB outcomes, and these are actually pretty significant. So preterm labor and preterm delivery, preterm premature rupture of membranes, both of which can cause both preterm labor and preterm delivery, spontaneous abortion or miscarriage, chorioamnionitis, which can cause preterm labor, preterm delivery, endometritis, which is related to chorioamnionitis, wound and surgical infections, which can relate to a C-section. So you can see some really big problems here. If a woman has BV in pregnancy, she's susceptible to these things. Now, this does not apply to having BV before the pregnancy. That doesn't confer a risk when you do get pregnant, as long as it's treated. But if you get BV during pregnancy, it can be associated with these things if it is not treated promptly. The exact mechanism behind BV is unclear, but we have a pretty good idea of it, and it's probably due to a disturbance of the vaginal flora. So the vagina is primarily colonized by Lactobacillus species. And lactobacillus is a bacteria that makes lactic acid. And so what probably happens is that the lactobacillus is disturbed for one reason or another. One of the big reasons that can happen is vaginal douching, where a woman flushes out her vagina. That disturbs the lactobacillus. And because the lactobacillus is now gone, it's not making lactic acid. It's going to push up the pH of the vagina, and that's going to allow other bacteria, more nefarious bacteria, if you will, to come in and colonize the vagina. And those are anaerobes and microaerophiles, things like Gardnerella primarily, also Bacteroides, and I think Mycoplasma is another one. So other bacteria will come in and fill the void. It's really just a free-for-all. Some of the risk factors include vaginal douching, also oral sex during menses for some reason, new or multiple sex partners, early age of sexual intercourse, sexual activity with other women, intrauterine device placement, black race, and smoking. The ones you want to remember, there's an increased risk in African Americans, increased risk with smoking, not exactly sure why that is, but the big one is vaginal douching. This is really a no-no for women. Women should not be doing this, okay, because this increases the risk for BV. The clinical manifestations are pretty limited. It's just this gray, thin discharge. A lot of times they'll notice it in their underwear, or they may, their partner may notice it during oral sex. They'll say there's kind of an odor down there, it really stinks, or it's kind of classically described as fishy smelling, but that may not be described to you. Okay, it may be odorless. So one of the ways that you can really unmask that fishy smell if it's not described to you offhand is you can, when you put this discharge, as you will, when you put it onto a slide, you'll add a little bit of potassium hydroxide to that. And that potassium hydroxide will really unmask that odor, and you'll take a little whiff of it when you add the potassium hydroxide, and it should give you a potent fishy smell to it. And that's called a positive whiff test, and that happens to be one of the diagnostic criteria for bacterial vaginosis. So the physical exam will be unremarkable. However, if you do a pelvic exam, as you should, you may note on your exam finger, you may be able to note that fishy smelling discharge. But this should be a gray to clearish colored thin discharge. It's not going to be curdy white. This is not like a yeast infection at all. And that's the other thing that's going to help you distinguish this from a yeast infection, is that there is no vaginal discomfort. There's no itching or burning that we see with a yeast infection. It's just the discharge, but it's a smelly discharge. And so that's often what's going to prompt the woman to come in. So to diagnose this, it's a saline prep. You add some potassium hydroxide to dissolve some of the residual material. You're left with these cells, and these cells are stippled with Gardnerella bacteria. And that is what causes this appearance. This is just a vaginal epithelial cell stippled with Gardnerella, and we call this a clue cell, and this is diagnostic for BV. The vaginal pH, if you test it, will usually be elevated. It should be elevated because of the absence of lactobacillus, which would normally keep the vaginal pH under 4.5. You take that lactobacillus out, there's less lactic acid, that pushes the pH up above 4.5, and so you have a relative alkaline vaginal pH. Okay, so note here that this is exactly the same way we go about examining the woman and diagnosing the woman with BV, just like we would outside of pregnancy. So these are the clue cells here, vaginal epithelial cells stippled with Gardnerella bacteria. So you can see it along the periphery of the cells and then up here. So these are just, these should be normally, these would be nice clear cells here, but you see all this junk, and this is bacteria. The treatment for BV during pregnancy is the exact same as outside of pregnancy. The drug of choice is Flagyl or metronidazole, and the dosing for that, if you want to write that down, you don't need to know it for the test, it's 500 milligrams twice a day for a week. And that is what we give. It typically will resolve the BV because it will kill off all those bacteria that are not supposed to be there. As far as I know, lactobacillus is not affected by metronidazole, and so it allows the vaginal flora to come back as it should. Alternatively, you can use clindamycin, but metronidazole is going to be the drug that they'll test you on the USMLE. Okay, both of these drugs are safe during pregnancy, so you don't need to know any different treatment during pregnancy. So you may be asking yourself at this point, especially if you just watched my lecture on UTIs in pregnancy, both are associated with adverse outcomes in pregnancy. And with the UTIs, particularly asymptomatic bacteriuria, we do a screen. We do a screen at the first visit. Why don't we do that in bacterial vaginosis? The reason we don't do it in bacterial vaginosis is because we've found that doing screenings, we've tried doing screenings, it doesn't improve outcomes. Now with the asymptomatic bacteriuria, we know that there's a 30 to 50% likelihood that those women are going to go on to develop pyelonephritis. And pyelonephritis is not only dangerous for the pregnancy, it's dangerous for the woman herself. She can get a systemic inflammatory response syndrome, she can get pulmonary edema, sepsis, and so it's really important with asymptomatic bacteriuria to do a screening because we need to get on that, especially for the mother's sake. But we've tried screening in BV, and what we found is it just does not improve outcomes in women in general. However, there's a little caveat to that. So the USPSTF does not recommend screening asymptomatic women, meaning universal screening, in women who have a low risk for preterm delivery. They recommend against screening in that case. However, women who are asymptomatic, who have a high risk for preterm delivery, so let's say they've had preterm deliveries in the past, or maybe they've got something like cervical insufficiency, actually the evidence there is unclear. So the USPSTF has concluded that current evidence is inconclusive for screening for BV. So if you have a woman who's had previous preterm births, or she's got an insufficient cervix, you may want to consider doing a screening for BV, especially if she's had diagnosed BV in the past. Okay, so that is rather up in the air. And as a matter of fact, if you go north of the border, the Society of Obstetrician and Gynecologists in Canada has actually put out a statement supporting screening, universal screening for BV in women who have a high risk for preterm delivery. And the big risk factor for preterm delivery is previous preterm deliveries. And they recommend doing the screening at about 12 to 16 weeks, so right around the beginning of the second trimester when she comes in. So if she has a history of preterm delivery, to do a screen for BV. Okay, but that is not necessarily recommended in the US, but it's not recommended against. So that is for women with high risk. But if she's asymptomatic and low risk, nobody believes that you should do screening for BV in that instance. Okay, so asymptomatic and high risk, it's inconclusive. You may do it, you may not. On the test, you will not be asked that question because it is inconclusive at this point. All right, so if you have any questions, write me a note below. Otherwise, I will see you next time.